Hi, listeners. This is a quick thank you for listening and for your ongoing support. If you're enjoying the program, please consider clicking the follow or subscribe button if you haven't done so already. It really helps us out. There's no better way to support us than doing that or sharing the show with a friend, colleague, family member, or any new or expecting parent in your life. It's totally appreciated. On with the show. Hi, I'm Sarah Trott, and welcome to the Fourth Trimester Podcast. I'm a new mama, and this podcast is all about postpartum care for the first few months following birth, the time period also known as the fourth trimester. My postpartum doula, Esther Gallagher, is my co-host. She's a mother, grandmother, perinatal educator, birth and postpartum care provider. Fourth trimester care, our topic, is about the practical, emotional, and social support parents and baby require. And importantly, it helps set the tone for the continuing journey of parenting. Welcome to the Fourth Trimester Podcast. I'm your host, Sarah Trott, with my co-host, Esther Gallagher. And today we're talking about a critical topic. We're talking about the prevention, warning signs, and treatment of preeclampsia. This is information you need to know before you leave the hospital. It's a disease that's been in the headlines numerous times because of celebrities who have had it. I mean, you probably heard like Beyonce, Mariah Carey, Kim Kardashian. There are lots of very famous cases of women who have shared their stories. And of course, the very heartbreaking stories that we read about, cases of mothers who have lost their lives. One notable recent tragedy was Olympian runner Tori Bowie. So this is a very real and very serious disease. And today, to talk about it, we're joined by Dr. Amanda Williams, who is a board-certified OBGYN, and she is nationally recognized. She is a leader in maternal health, and she brings decades of clinical experience and health equity leadership. So we're really honored to have her here, and Dr. Williams will help us understand what parents and caregivers and everyone needs to know about preeclampsia. So before, during, after pregnancy, and we really want to make sure that parents and caregivers have information they need to protect themselves and their babies. So welcome to the program, Dr. Amanda.
Thank you so much. I'm excited to be here. This is probably my favorite topic in all of obstetrics. So I'm glad to talk about it both from a clinical and patient experience and family perspective.
Yeah, we're so excited to have you here and talk about this. We were chatting, we hit record even before we officially kicked off with this show because we just kind of dove right in and talked about it. So why don't we revisit some of that from your perspective?
Sure. So I'm almost embarrassed by the arrogance of it, but I was 29, 30 years old when I was pregnant with my first, and I was the chief resident in obstetrics and gynecology at University of California, San Francisco, arguably the best program in the country, knew all about preeclampsia, and was a former Division I varsity athlete. And I didn't think at all that this could be possible for me. Now, mind you, in retrospect, of course I was at risk for preeclampsia. I was a Black woman having my first baby. I have a family history of high blood pressure. And indeed, my grandmother not only had preeclampsia, it was called toxemia back in the 40s and 50s, but she lost a baby. And that's sort of part of our family lore was that there was this baby Wendy that my father was so excited was going to be coming home, his little sister who never came home. But I thought, well, I'm different. It's the 2000s. It's going to be different this time. And I'm so healthy and I'm so knowledgeable. This couldn't possibly be. And I was at work and had been operating all day, and my feet got super swollen and my face was swollen. And I thought, oh, it's just because I've been operating all day. Like it couldn't possibly be preeclampsia. And a colleague said, well, let's just check your blood pressure to be on the safe side. And it was like 175 over 100. I was like, what? This is crazy. And the long story short, it turned out that I had severe preeclampsia. My son was born at 35 weeks. I was not on low dose aspirin, which, of course, today I would have been and certainly would have taken if I had had that opportunity. He spent 10 days in the NICU, which were 10 of the hardest of my life. And though many have much longer NICU stays, I do not wish that on anyone. And now he is 21, and now I have chronic high blood pressure. Despite being healthy and active and normal weight and doing all the right things, preeclampsia does remold your cardiovascular system. So, uh, my own story is sort of a testament to the fact that it can happen truly to anyone, but that there are things we can do to decrease the likelihood, to push it to later in pregnancy, to make sure that you're being monitored postpartum, and then preconception before a second pregnancy, things you can do to get yourself ready, and then the long term consequences. So I'm happy to talk about all those things.
So I'm going to jump in and I'll tell you my little story. I have not experienced this personally, but I've worked with many clients over my 35 plus year career who have had preeclampsia either during pregnancy and or postpartum. And in fact have been the person to flag it on a handful of occasions because nobody else was doing so. And so it's real. It's very real. When I was first starting out forging along the path of my interest in all things pregnancy, labor and birth, and postpartum related, amongst the books that I read at the time, and we're talking the late 70s, it had been shown that preeclampsia in those days was seen to be a disease of poverty, but specifically because people living in poverty were not getting enough protein, essentially. They just weren't throughout their lives getting enough protein to build strongly integrated cellular system throughout their body. And so that put them naturally at risk.
So to be clear, that is not the current
Thinking.
pathophysiology of preeclampsia.
Okay. And it was shown at the time that if you fed people higher protein diets, they had statistically a much better outcome. And I will note that this was flagged amongst African American populations at the time. I'll just say that as well out loud. That this is where it was showing up the most because who was living the most in poverty? It was African American women. And so I'm curious then, of course, what's the thinking now? Because it does seem that so many of the dysfunctions of pregnancy and postpartum would be ameliorated by better public health and nutrition and exercise throughout life, not just when suddenly you get pregnant, you can get WIC and you can do the things, right? But that, we undernourish people in this country from birth. And we can see that it's not a disease of poverty per se. I think it's a disease of stress as well.
So preeclampsia is diagnosed as a syndrome. So there's a whole complex of different changes that happen that are part of preeclampsia. Preeclampsia is not just one entity. And so what we're looking at is the sort of the end of what's happening in somebody's life up to that point. And we're seeing the high blood pressure, we're seeing the spilling of protein in the urine. We may be seeing lab abnormalities in terms of liver function, in terms of kidney function. But there are actual changes in the pregnant person's biology at the very beginning of pregnancy. And now there are some tests that are available to start looking for some of those changes. And it has to do with the vascular modeling of the placenta. And that's sort of at the heart of it. And in that vascular modeling, what we're seeing is, and where stress ends up being biological, is inflammation, chronic inflammation, and oxidative damage. And so it's not something that a person is doing wrong. And I think that's a really important message. But there are some people who are exposed either to physical stressors or psychological stressors that end up with this then biological signature. And that's sort of the concept of epigenetics. So one might have a predisposition for something that then comes to light because of the environment that they're in. So that's part of the reason why things that are difficult to talk about, like exposure to racism, exposure to poverty, exposure to obesity, chronic hypertension, twins, all of these things are stressing one's body. And if that's what you're coming into or experiencing pregnancy with, that is then increasing the likelihood of developing preeclampsia. And so I think your point's very well taken, Esther. Coming into pregnancy more healthy has the potential to improve outcomes for sure. But we're maybe not going to undo 400 years of systemic racism bias in our country or undo the effects of poverty in the time of a pregnancy, but we can help equip people to be able to respond to those situations.
And is the aspirin recommendation, is that across the board now for pregnancy, or is that specific to women who might have been deemed in some way high risk? So for instance, if they already have a chronic inflammatory disorder like arthritis or something of that nature.
So I would encourage everybody, all of your listeners, to go to the March of Dimes website or the California Maternal Quality Care Collaborative website, that's cmqcc.org, to look at what the risk factors are. So there are some risk factors that are really strong, like being obese, having hypertension already before pregnancy, having twins, having lupus. Some of these are the highest risk factors. And then there are more demographic risk factors, such as being over age 35, being exposed to systemic racism, being low income. Those things are more demographic and sort of societal type stressors. But there are very clear risk factors where the midwife or physician should be recommending aspirin. In some settings, like a federally qualified health center where most of the patients might be low income and insured through Medicaid, they give it to everybody because essentially everyone is at some sort of increased risk. And that way people aren't slipping through the cracks. And so both March of Dimes and CMQCC are putting a lot of effort into how do we get this knowledge out there to the community, to providers, and build systems in sort of using quality improvement methodology, implementation science methodology, so that these things don't get missed.
I love those resources. We're going to make sure we put them in the show notes to make them really easily accessible for our listeners. And just in terms of understanding the basics, you touched on it before, but what exactly is preeclampsia and how common is it among pregnant people?
So, preeclampsia is a condition of the end of pregnancy and postpartum where you have high blood pressure, so increase in either the systolic or diastolic, the top or bottom number in your blood pressure, and usually protein in the urine as well. There are other parts that can be part of the diagnosis, such as abnormal liver function, abnormal kidney function, severe headaches, blurry vision, liver pains, that's right under your ribs on the right side, excessive quick swelling. And you'll notice that some of these things are common in pregnancy and postpartum, unrelated to preeclampsia. So that's why it's so important to take the concern seriously if these symptoms start arising and making sure that it isn't preeclampsia. But we make the diagnosis initially by 2 blood pressures at least 4 hours apart, of the top number being over 140, bottom number being over 90, and a new onset protein in the urine.
Okay. When we had a prior conversation on this show, I remember one of the ending points that you made, we were talking about baby registries, I think it was, and you said, "You don't need a onesie, you need a blood pressure cuff,"
Yes.
right? And this is for exactly this reason.
Correct, because that's why they call hypertension the silent killer. You often don't get symptoms, so things that you feel, until those numbers are really high. I did an interview recently and I said, forget the bouncy seats, forget the dresses, forget the onesies, a blood pressure cuff and a postpartum doula. Like, that is what I recommend for new parents having, expanding their family, because that is what is going to really keep you safe.
Yeah.
Can I jump in with a question? I agree with that. And by the way, preeclampsia is only one blood pressure condition. And so I wonder if you would talk about the basic differences that I'm sure they're similarly highly concerning, but there's a thing called pregnancy-induced hypertension, which, by the way, can be chronic for mothers over different pregnancies, it would appear, and then preeclampsia, because there must be some kind of difference in there. And I'm curious if you could talk about sort of the subtle or not so subtle differences in those diagnoses.
So I will tell you that pregnancy-induced hypertension has kind of fallen out of favor in terms of language that we use clinically. So we take a big umbrella is hypertensive disorders of pregnancy. And it comes in a lot of different flavors, as you're alluding to. There's chronic hypertension. So that means hypertension or high blood pressure before 20 weeks of pregnancy. Some people might know that they had it before, maybe they didn't, but that's chronic hypertension. And with that, you may or may not have protein in the urine already. And you may or may not have normal kidney function. But the key is that it can get worse with pregnancy, but it didn't start with the pregnancy. Then the next level is, it's called gestational hypertension, which is the old pregnancy-induced hypertension, which is when you have, after 20 weeks, elevations in blood pressure that are not associated with protein in the urine or any other lab abnormalities or symptoms that is showing that your organs are now being impacted. And then next level up is the preeclampsia, where you have the blood pressure and the spilling of the protein, or if you also have any of those other features, the abnormal platelets, so that your blood's not clotting as well, liver function abnormalities, kidney abnormalities, etc., or a severe headache that doesn't go away with Tylenol, or vision changes associated with it, liver pain. All of those things are showing that the preeclampsia is getting into the severe range. So we call it preeclampsia with severe features, like the ones I just described, or without severe features. So all of those sort of create a spectrum. And then at the far end is HELP syndrome. So HELP stands for hemolysis, which is the breaking up of red blood cells, elevated liver enzymes. So the blood pressure has actually affected your liver, and then low platelets. So the blood vessels are so damaged that they're now damaging part of your blood that helps it clot. So that is a huge spectrum. It's more than any person really needs to stay on top of, but to know that it is worth taking one's blood pressure and listening to symptoms. And that's also where doulas, family members, partners really come in, is taking people's symptoms seriously. If you have a headache, don't just blow it off and say, oh, honey, you're fine. Oh, you're tired. You just have a new baby. Like, those things can be true. And you can also be showing signs of preeclampsia.
Right. So that would be a time to take blood pressure, right?
Exactly.
Speaking as the doula, and I send this out to every single postpartum and prenatal doula that I know is in the world right now, take these things seriously. Even if it's just one of the symptoms that Dr. Amanda has been willing to share with us today, any one of these symptoms ought to be taken seriously. No joke. Don't be in denial with your clients. Yes, they wanted that wonderful home birth. I want that for them too. You all know that. But now is not the time to go into it's probably nothing. Why don't we just wait it out? Absolutely not. Call the midwife, call the obstetrician, be seen as soon as possible by somebody who can big picture this with you.
And I so appreciate that, Esther, because doulas can be those critical bridge builders and know how to speak medical enough to help escalate that concern. Because,
Mhm.
for better or for worse, we live in a country where certain voices are designated as more important than others. So if a patient is calling, and let's say they are a young woman who doesn't have a ton of education, doesn't know the quote unquote right words to say, they may be blown off and they may not really be listened to. And God forbid they don't speak English. God forbid you're a person of color. All of those things then get escalated. And so to be able to say to the provider, my patient is having headaches. She took Tylenol, she nabbed, it didn't get better. I really think she needs to be seen. Please bring that patient to the hospital. So,
Yeah.
how great to be wrong. I say this to patients all the time.
Yes.
I want to be wrong. I do not want you to have preterm labor, preeclampsia, whatever it is. But let's be sure. Let's reassure ourselves so that we can then go on with this process.
Yeah. And while it will be stressful to leave your home, to go to the place, to get seen where there's all the testing available, it might save your life and or your baby's life. And so it's no joke. And I want to say to my doula sisters as well, be the person who escorts them.
Yes,
Clear your day and just say, we're going and I'm going to stay with you the whole time
absolutely.
because I may be able to help you communicate with the people you're going to be encountering for the rest of your day today,
Hmm.
at least. Doulas, by the way, think of what you can learn by being willing to show up in this way. It's how I learned about this. It's how I know what we're talking about right now and how serious it is.
And you asked me a question, Sarah, that I didn't realize I didn't answer in terms of prevalence. So it feels like it's all over the place because lots of celebrities have had preeclampsia, and it's great that people are speaking up about it. It is about 5-ish%, 5 to 10% of pregnancies, depending on your geography, where you are. But it's the most common complication of the pregnant end of pregnancy and postpartum, and is the number one cause for postpartum readmission to the hospital. And it can be that readmission can potentially be prevented if it's picked up early.
Right. Yeah. Thank you. I was going to come back to that because I was curious. I mean, 1 in 10 pregnancies, that's not totally uncommon, right? So, as you said, it could be anybody. And your story speaks to that. You were very healthy, you're well educated, well informed, and there you go. So, it could be anybody. And we've had conversations about technology too. You can get an at home tool to help you monitor your blood pressure. And it's not that obviously you can't self diagnose, but you can collect data on behalf of yourself. And that data can help you and anyone you're working with. Like Esther was saying, if you have a postpartum doula or like someone who's a doula working with you during your pregnancy, right? They can help advocate for you and use that data to your benefit.
Absolutely. And I think there's a huge role for technology here and leveraging of virtual care, especially in the postpartum period. Once you have a new baby, every time you step out of your house, it is a production, literally just to go to the grocery store. So imagine if it's to go.
You heard it here from an obstetrician. I just want to say this out loud. You know that I say, stay home, stay home, stay home, stay home.
Right.
Here's somebody who had to do it.
Exactly.
They know it's not pretty or fun or anything, but do it anyway. Yeah.
Yes. And so that's why having a blood pressure cuff at home, and we love seeing more and more healthcare systems giving patients blood pressure cuffs, particularly if they're Bluetooth enabled or wireless enabled, so that those blood pressures get uploaded. And then there's a nurse who's watching the blood pressures as they come in and can outreach to the patients. So hopefully your health system has that available. And if not, get a blood pressure cuff for yourself. It's worth registering for. And you're not just going to use it for pregnancy. You can then give it to your aunt who has high blood pressure. And so you're actually giving a service to your family and to your community, because I can guarantee you somebody you know has high blood pressure, and they can take advantage of that blood pressure cuff after your pregnancy is over.
Yeah, it's not going to go to waste, right? And even if you have your own and you're just writing your data down with pencil and paper, that's valuable because you can communicate that. And back to your point about telehealth. So you said if you catch this stuff postpartum, you can prevent some of those readmissions. Tell me more about that.
So the idea is to catch the blood pressure as it's going up. So almost everyone, essentially, it is a physiologic part of the early postpartum process. It's called intravasation. So you have all this blood in your body that was going to feed your baby and was going to your uterus. There is no longer a baby in there. And so you've got all this extra blood volume, and it has to go somewhere. So it's going in your system now. And you have all this fluid that's in your tissues. So almost everyone has a little bit of swelling in their limbs at the end of pregnancy. It has to intravasate, which means come back into the blood vessels. And so when you have that higher volume in the blood vessels, it inherently pushes up the pressure. That's why we call pregnancy and early postpartum the cardiovascular stress test, because you are stressing your system with this increased volume. This happens quite reliably between days 3 and 7 after the birth. That also tends to be when people are going back home. And so, how is one's body going to tolerate this? That's why, for anyone who has chronic hypertension, gestational hypertension, preeclampsia, anything that's diagnosed, and I would argue essentially everyone should be checking their blood pressure in that time, because if you notice it creeping up, you can start blood pressure medication to keep it from getting to stroke levels. And that reminds me, Sarah, we didn't talk about the two big things that can happen as consequences of severely high blood pressures and of preeclampsia for the parent is strokes and seizures. And so that very high blood pressures, so when they're getting over 165 for the top number, over 110 for the bottom number, and oftentimes it's accompanied by a headache or visual changes, that can actually have you can actually have a stroke with lifetime neurological deficits. And then you can also have a seizure. Oftentimes, the seizures are predicated by headaches, which again is why do not blow off that early postpartum headache in that first week. It could be caffeine, it could be dehydration, it could be rest, but preeclampsia is too big of a deal to just blow it off and say that, oh, you just need more rest. We have to be able to catch this so that we can respond appropriately.
Yeah. And if you are someone who doesn't have a postpartum doula, who maybe doesn't speak some of the language very easily, and you do have a headache and you want to get the attention, what's some of the language that you would encourage people to use if they want to be taken seriously?
To let the provider or the nurse, usually at the call center, say, I have hydrated, I've taken Tylenol, and this is a headache like I've never had before, or this is the worst headache of my life. Like, let them know that you've tried the common things and that this headache is different. Or if you do have a history of migraines, this feels different than my migraines. to really try to emphasize that this is something out of the ordinary that is happening. I would also, if you don't have a postpartum doula, make sure that your family is educated, your partner is educated about warning signs. I really like the A1 infographic on postpartum warning signs. And I recommend to all my patients just stick that on your refrigerator or your family bulletin board or something like that so that everyone can see, like, if these things are happening, any of them, they are to be taken seriously.
Yeah, and that could be something, Esther, folks in your profession could carry around and help educate and share.
Beautiful, yes. And I would also just mention that while not everyone will be able to avail themselves of this, we do have, in the Bay Area, because we do have certified public midwives, LPMs, et cetera. I'm not sure what the proper title is in California currently, but these are care providers who do home visits. So you can get clinical postpartum care in home so that there's somebody visiting on strategic visits in the first week to all the way out to 6 weeks to come in and check for just these things for mom and baby. And so that's a pretty excellent form of care. It doesn't preclude also having a postpartum doula, but it does up the level of sort of clinical care that you can have in home before you then have to feel like, okay, yeah, now I need to go to the hospital.
And thank you for bringing that up, Esther, for our California parts of the audience. There are, and in many places across the country, it's called Nurse Family Partnership, that does home visiting nurses, is a public health service that is available in many communities. And then, as you said, licensed midwives, professional midwives who might be doing home care is another opportunity. At the California Maternal Quality Care Collaborative, based at Stanford, which is a public-private partnership with the California Department of Health, helped get it started. We are working on a big discharge landing page so that hospitals all over California and then some of the lay community as well can have a single place to go to look for resources for taking care of patients as they leave their maternity hospitalization.
Do you have any comments on the state of rural healthcare for the perinatal crowd?
Girl, that's a whole nother episode.
I know. I'm so sorry. I bring it up because I have family and grew up rurally.
Yes.
So I
I have big feelings. I have very big feelings about it. So that is work. Again, both of the institutions that I'm most recently part of, March of Dimes and CMQCC, have been working very hard on looking at and helping to support our maternity care deserts. And so that phrase has come under some scrutiny, but to be specific about what it means, it is a county. So a county level designation where there are no hospitals with labor and delivery units, licensed birth centers, obstetricians, family practice docs doing obstetrics, or midwives. So a whole county that has none of those things. 35% of counties in the United States of America in today are maternity care deserts. It is stunning to know that we live in this big industrial country, this quote unquote developed country, and yet we don't take care of our moms and babies. It is horrifying and it is getting worse. There were just in the last count, and I did not look it up right before this interview because I did not know that we were going to talk about it, but we lost over 100 maternity hospitals between the last two times that the count was done. And so it is a big deal. And even in California, we have many rural parts of California where it is very difficult to access care. And so that's why knowing where your closest hospital is, leveraging care from community health workers, doulas, other types of providers that can help bridge build, taking advantage of virtual care and care at home. All of those things can be part of building an infrastructure to support our rural communities, especially with postpartum complications like preeclampsia.
And we
Yeah.
have talked about that report before. It's very surprising because you think, we're so modern here in developed nation, but it is stunning. That's the perfect word for it to hear that kind of result.
Well, I would also say to young families, if you're thinking about having a baby, know that. People will often, when they're like buying a house or looking at a community to move to, they'll say, what is the school system like in this area? But they need to know what the medical system is like in that area also. Will they be able to get good pregnancy and postpartum care?
And pediatrics.
And yeah, exactly. Like
Yeah.
what does the medical care look like in the community where you're thinking about moving?
Mhm.
Well, yeah, and to bring the point back to preeclampsia specifically, if you are that 1 in 10 pregnancy and you are experiencing this complication and you're in one of these places, that makes it that much harder and riskier, right?
Absolutely. And all the more reason to make sure that you have a blood pressure cuff at home, that you have someone, even if it's just your partner or your mom, who knows the warning signs so that they can flag that for you. Also, and I'm sure this is something, Esther, you talk about with your patients a lot, getting your call list ready. It's even a bigger deal
Yeah.
in rural communities when it might be a longer drive to the hospital, but making sure that you have, this is my neighbor who I know, if you have an older kid at home, that like can be with my toddler or preschooler while I have to go to the hospital. Or if you live by yourself and your partner might be at work, for example, who would I call in case of an emergency? So going into your birth, not just who will take me to the hospital for labor, but who will help me if I have a postpartum emergency also.
And actually, so if someone goes through their pregnancy and they've gone home and they've got a couple weeks under their belt and they're, recovering along the path that everyone is deeming is okay, are they in the clear? There's no more risk of preeclampsia, or how far down the road can it develop postpartum?
So, the vast majority of postpartum preeclampsia is in that first week, certainly the first 2 weeks. So, when we
Okay.
look at when deaths from preeclampsia happen, the time that's outside of that is very, very small. It is not zero, but if you have had the normalization of your blood pressure after those first couple weeks, it's incredibly unlikely. Now, if you develop the symptoms, if you develop severe headache, blurry vision, liver pain, it's still something to have on, quote, the list. And if you are seeking medical care, going to an emergency room, calling a call center, always tell them, and I just had a baby. Because our
Yeah.
tolerance for high blood pressure is very different for someone who's in the postpartum period as opposed to someone who hasn't had a baby recently.
Yeah, important information to share on the call.
Yeah.
Is I'm not just like, someone who has a headache at home, like, "No, I just had a baby."
Right.
Yeah.
And in fact, Preeclampsia Foundation has a big project called the Blue Band Project, where they do those blue sort of plastic bands and give them to everybody who had a hypertensive disorder of any of those different types we talked about earlier. You go home with a blue band and you wear your blue band until you come back for a postpartum visit at 4 to 6 weeks. You should have had I was like, public service message. You should have had a touch point before then. But until you have that appointment at 4 to 6 weeks, you wear your blue band so that if you end up in an emergency room at a hospital that's different from the hospital where you delivered, that people remember that you recently had a baby and had hypertension
Yeah,
problems in pregnancy.
got it. That's so handy. Yeah, and you'd wanna keep it on until at least 6 weeks postpartum.
Hmm.
Nice one. So then if you do go in, if you're seeing the signs, you do go in for treatment, what does the treatment look like, and what are the outcomes that a parent could expect?
So there are a couple of different things that we do for a patient when we admit them for postpartum preeclampsia. The most important one is control their blood pressure. So we may give them IV medicine to bring it down quickly and prevent stroke, and then start them on an oral medication. The medication that's been the best studied in the postpartum period is nifedipine. It has the best results, and there are multiple what we call meta-analyses, so studies that take multiple studies into account that tell us that if you can tolerate it, is the best medication for postpartum preeclampsia. We also will often start a patient on magnesium, which is just like magnesium, like it's an electrolyte. It comes from dirt that has been shown to decrease the risk for seizures. So when you have preeclampsia, you're actually having swelling in your brain, which is scary to think about, but it's a real thing. And the magnesium helps decrease that likelihood of seizures. So that's what you would expect. Hopefully, wherever you're being admitted, would it let you keep your baby there? You and your partner and baby can stay as well. But if for any reason that's not the case, or if it's your preference to leave baby at home, make sure that you ask for a hospital grade breast pump so you can continue your pumping while on magnesium and nifedipine. And both of those medications are safe for breastfeeding as well.
Okay, good to know. And then we talked about prevention a little bit earlier. Should we talk about that? Is there anything else we want to outline for parents who are thinking about pregnancy and expect, or maybe they are pregnant already?
Absolutely. And if you have any of this history in a prior pregnancy, you absolutely are at increased risk for it in a subsequent pregnancy and need to be on low dose aspirin. So again, low dose aspirin, simple, over the counter, 81 milligrams. You can get it at your CVS, Walgreens, whatever, Safeway pharmacy, is absolutely life saving. And this simple over the counter once a day can help decrease the likelihood of preeclampsia and the associated preterm birth. And there's some data actually independently preterm birth might be decreased as well. We talked earlier about some of the risk factors for preeclampsia, and very healthy people can be at increased risk for preeclampsia. It doesn't mean that your whole pregnancy is high risk. It just means that you are at increased risk for this one particular condition. And knowing the warning signs and taking your low dose aspirin can make a significant difference, can decrease your chance of preeclampsia. And, we didn't talk about the fetal consequences, but there can be poor growth. So, fetal growth restriction, or small babies with poor blood flow and oxygen, or even stillbirth, are significantly increased. And then C-sections as well, all increased with preeclampsia. So you are protecting not just yourself, but also your baby.
Those are serious implications. And so if you are experiencing preeclampsia, like what are the long-term health impacts for the parents and babies then?
So for babies, once they're out, they're good. They may have consequences of being premature, and they had to be born prematurely because the mom had preeclampsia. But once they are out, for the most part, they are good. Some data around hypertension in later years, but those studies are still sort of in process. With the parent, it is very well established that not only will they have increased risk of preeclampsia in a future pregnancy, they are at increased risk for chronic high blood pressure and for stroke in the future. There is actual vascular remodeling that is happening with the preeclampsia. And I remember, oh God, I remember it so well. So I was 30 when I had preeclampsia. And then once I turned 40, I was diagnosed with chronic high blood pressure. And I was pissed. Like sorry, I shouldn't say that.
Mhm.
I was mad.
No.
Because
Please say that.
I felt like it wasn't fair. Like I was
Yeah.
healthy and I ate well and I was a normal weight and I exercised almost every day. And it just, I felt almost, and it's kind of disgusted with myself that I felt so angry, but I'm being honest. I felt really badly about it and was resistant to starting medication, but I eventually did because at the end of the day, you can't fight your genes and you can't unlive your lived experience. So instead, I take it on and I educate others about it.
Well, thank you for educating us and our listeners. It's such a pleasure, and it's a lot of good information here. What else have we not covered that you want to make sure we get out there in terms of messaging?
I don't want it to be you. I don't want this for anyone. And we have to live in the reality that it might be anyone. So if you are a pregnant person, put this layer of armor of low dose aspirin on around you. I can't fix poverty. I can't fix you being 40 and not finding the partner till you were 38 that you wanted to start a family with. I can't fix that your IVF left you with triplets. Like, I can't fix systemic racism, but I can help protect you against the consequences of these things. And so, if low dose aspirin and knowing the warning signs and checking your blood pressure at home is going to lead you and your baby to having safer outcomes, then let's do that.
Yes. Thank you so much.
You're welcome.
Wow.
It's such a privilege to be here.
Oh,
I really, enjoy the fourth trimester. I'm such a believer. In fact, I just sent it to a pregnant colleague who's 32 weeks just day before yesterday.
wow.
She was, Amanda, of all the things that are out there, like what are the resources? If you had to pick like 3 or 4 things out there for pregnancy and postpartum, it is always towards the top of my list.
Oh, we're so
Wow.
honored. Thank you so much.
Gosh, that is fantastic. That just warms my heart so much.
We're really happy to give a platform. This is such important information, and it's so impactful. And we believe in democratizing information,
Yes.
and we believe in sharing science, especially from people who do have the credentials.
Yoo-hoo.
Yes,
In fact,
absolutely.
I'm not going to start for the 49ers next weekend. I'm actually going to take care of
What?
patients because with my medical and public health degrees, that is what I should be doing.
Wouldn't it be cool if the 49ers would do perinatal public health ads or right? Wouldn't that be great?
Actually, that is something that we were working on at March of Dimes. So the Commanders, there is one of their kickers was a preemie, and I think his mom was like a NICU nurse or something along those lines. And there are multiple NFL players who have made March of Dimes their charity of choice and talk about prematurity. And so I
Very cool.
love when people use their platform. Allison Felix has done an incredible job. Serena Williams,
Mhm.
Kim Kardashian's talked about it. There are a lot of people who are taking advantage of the moment, their ability to talk about these conditions that even with all of their privileges, even with their healthiness, things can happen. And I
Mhm.
don't want to pathologize pregnancy. We have survived as a species for millennia because it does keep going right most of the time. And I also know that it is my job to worry about the things that can go wrong and to help support patients so that they don't have to have that stress. But I want them to be educated and have the information.
Well, and I will just say, as I say often on the podcast, wouldn't it be nice if this information was being relayed amongst the male cisgendered population? Because after all, they're often deferred to when it comes to healthcare decisions during pregnancy.
And I do really appreciate, Charles Johnson and Bruce, forgetting his last name. There are some dad advocates out there that have been very vocal. March of Dimes did a dad symposium earlier in the year. We really need to educate partners because the vast majority of the time, the partner, the family members, like they are there. And sometimes they do feel helpless. Sometimes, and to be honest, as a healthcare system, we have not done a good job of engaging families. And so I always try to, in the delivery room in particular, say, do you have questions? What do you need to know? Or if, let's say, the patient speaks English and the partner does not, make sure we have interpreter for the partner, the family member. We want to empower our families because they love their pregnant person. And so we want to build this cocoon of caring around our expanding families, and having good partner engagement and education is part of the process. And I wish that we normalized that a little bit more. I have 2 sons, and I tell people all the time, like, I am raising young feminists. Like, these boys are going to stand up for their partners and friends and know, like, what it is like to be in these bodies and have these experiences, because it is not just for the women to carry that.
Well, since we're talking about this, I want to mention something that's relatively new. Maybe you've heard of it, but it's a document called Bringing the Father into Pregnancy. And it's available on dadcare.org.
Oh,
If
nice.
you've
I
heard of
didn't know
that,
that.
it was created by Dr. Ed Stevens. He's based in New York, and he's a lifelong psychologist. But the idea is that it's a questionnaire for dads, partners, to answer alongside mom during the pregnancy visits, because his whole point is like, we get depression too. We have mental health concerns. No one asks us anything. We just get kudos for driving to the appointment and showing up, but we're kind of left out. So since we're talking about the other side of things in a way, I thought I would mention this document as well.
Also, especially for NICU dads, I found that is a population in particular. When we live with this construct, like the dad should be the protector and should be taking care of the family, it's a place that can be very disempowering for everybody. And so really screening for postpartum mood disorders for both parents in the NICU. And I will say that's a project at March of Dimes that we worked on for quite some time, is getting depression screenings into NICUs. And so that families, both moms and dads, can screen themselves for depression and then link to resources and have I can't remember, it's staffed differently in different places, but with a doula or community health worker or nurse navigator who then can see, how serious is it, and get them to the right support.
Nice.
Brilliant. I love it. Well, we'll put a link to all of these resources that we've talked about. Love the conversation on preeclampsia, that deep dive, as well as this bonus conversation. I think we could talk to you all day, Dr. Amanda. We'll have you back soon to talk more. Thank you so much.
Thank you.
Thank you, Dr. Williams. Woohoo!
You can subscribe to this podcast in order to hear more from us. Thank you for listening, everyone, and I hope you'll join us next time on the Fourth Trimester. The theme music on this podcast was created by Sean Trott. Hear more at soundcloud.com/Sean Trott. Special thanks to my true loves, my husband Ben, daughter Penelope, and baby girl Evelyn. Don't forget to share the Fourth Trimester Podcast with any new and expecting parents. I'm Sarah Trott. Goodbye for now.
Hello again, bicycle man. I know you're doing all that you can. I wrote the song, simple and true. I wrote the song, I'll sing a song for you. You got your wheels, you got your gears. You ride around town without any fear. You got your pedals, you got your brakes. You always wear your helmet for safety's sake. Hello again, bicycle man. I know you're doing all that you can. I wrote the song, simple and true. I wrote the song, I sing a song for you. Hello again, bicycle man. I know you're doing the best that you can. I wrote the song, simple and true. I wrote the song, I sing a song for you.